So welcome back to this last afternoon. We will start with a 30 minutes discussion about the metrics to predict clinical success. And I think the discussion could be framed around two axes. I mean, what is clinical success? So what do we want to measure? And sorry, and how can we at the foundation help the community to get there? So, I mean, before we really start the discussion, I would like to open the talks from this morning from Dr. Shebani and Dr. Lavallée to questions, or if you have questions about the presentation of our guidelines. So if there are no specific questions, let's start. I will ask Dr. Shebani. I mean, very general question, but Natasha, do you think we are ready for the clinical use of imaging as a surrogate, or complement to more traditional, let's say, immunoassay, or what is lacking and what should be the next steps?
Yeah, you know, I'm hard pressed to say that we're at the point where imaging can be used as a surrogate. Certainly, I think there's a lot we still have to garner by way of deep biology and the immunoassays that you beautifully talked about during your overview of the guidelines. I do think, however, that, you know, FUS, of the many technologies or therapeutic strategies you think about, FUS is particularly ripe in terms of leveraging imaging data because it is an image-guided modality most often at the end of the day. So in a lot of our preclinical and clinical trials, we are already gathering loads of imaging data. And the question becomes, should we extend that further to include other functional or quantitative imaging metrics? And my personal bias is yes, we should. And I think we're seeing in the emergence of literature that a lot of other people are considering this as well. But, you know, big picture, I think alongside the immunoassays, it would definitely behoove us to try and collect imaging data in parallel. And the reason for that being that as we collect these data, again, we're going to open ourselves up to the possibilities of being able to use techniques in imaging informatics in the future. And this could potentially help us years from now get to the point where we actually do have non-invasive imaging biomarkers that can help us better surveil or perform risk stratification in the context of combinatorial immunotherapy with FUS.
And in terms of imaging, are we looking at specifically CT, MRI, ultrasound, or?
Yeah, you know, I think that those are definitely being used and are absolutely possibilities to leverage in this context. Like the study I highlighted was garnering radiomics features from CT, and certainly the same has been done for MRI. But I think the really exciting opportunities actually exist with, for instance, PET imaging. And again, that's something that's just now coming on the horizon in terms of being a modality that we're thinking about in conjunction with FUS. So I think the more robust opportunities actually exist with, you know, equally robust imaging, quantitative and functional imaging techniques.
Thank you. And Dr. Paklova?
Yeah, I just had a quick question. Are there any checkpoint inhibitors that are approved that are radio labeled for CT or PET currently, clinically?
So I am not sure about the approval status, but there is definitely published literature out there on radio labeled checkpoint inhibitors that have been, for which data has been published in humans. So those definitely exist. And they are, I think, in the context or, you know, relevant to like the checkpoint inhibitors that a lot of people on this call are using in their preclinical and clinical studies.
Dr. Bullock?
I'm particularly excited by the notion of the immunoPET for really sidestepping some of the issues that Joe Frank illustrated, and we've talked about biopsying patients, right? But I'm interested in your thoughts about the array of different immunopet agents that can be developed in this space. And are there any consequences to repeatedly imaging or infusing patients with imaging agents that could complicate the use of imaging approaches to understand, say, myeloid cell presence in tumors versus CD8 T cell presence in tumors?
Yeah, I mean, I would say on the preclinical side, this is what I find to be so exciting about the prospect of using immunopet imaging. As you mentioned, there's whether in mice or humans, there are only so many times that we can go and sample from the tumor, right? And there's a lot we can garner from the blood, and there's a whole frontier of liquid biopsy that's helping us, decouple mechanisms there. But the prospect of imaging, I think, ranges anywhere from imaging the actual drug to imaging immune cells that are responding to said drug. And sometimes those things go hand in hand as well. So, big picture, I think that with imaging, we still do have to have some pretty directed hypotheses, because at the end of the day, the probes we'd be administering would still be rather specific to one particular mechanism, or again, one particular drug. But as far as the complications go, I don't know that I'm best suited to speak to that. I mean, I see Kathy Ferrara just turned on her camera, and perhaps we have other colleagues who are more attuned to what the limitations are on the clinical side of things in terms of being able to implement these techniques.
Dr. Lavallée?
Maybe I'll make a comment and then let Kathy talk about, because I know she has a lot of work ongoing with different imaging agents. But I think there are, I know there are a number of CD8 PET compounds, including the one from Imaginab, which they just got a name, but I can't remember what it is. It's a zirconium labeled. And they've published and presented at several meetings. And the data are quite interesting. And I think they do give a way to look across the lesions at CD8, and they've even been able to image in the brain to see changes in T cell infiltrate in response to treatment. It does have logistical issues just in terms of administering imaging. It's another series of assessments, but I think it's an important tool to really consider. They've also published, pharma companies have published on PD-L1 imaging agents. And while the data are interesting, I think it's a little bit more problematic from the analytical perspective from our discussions with people. But I like the idea of really looking at the T cells and trafficking. And Kathy, I know you've done a lot of work with different imaging. If you have any other comments.
Yeah, I definitely agree that it's important. And we do have a whole suite of immunoimaging PET radio tracers at Stanford. Our lab had done, if you look at things we've published, we studied the Imaginab precursor. So it's a mini body that's labeled with zirconium. We have a paper on that, the diabody version of that with copper in preclinically, and looking at the response to immunotherapy and trying to understand it. I do think that that's a particularly promising agent, and doesn't seem to have, people were asking about consequences. It doesn't seem to have consequences in terms of T cell activation or other negative consequences in terms of T cell biology. Other things that we've learned, so you referred to our CD40 paper a little bit earlier. So this is interesting, we think, because CD40 is present on both tumor cells and myeloid cells, and so trying to understand which cells are actually expressing it as a function of time and treatment we think is interesting, and how does it change over the course of treatment. The other thing that we really learned, though, that was the biggest shock in that paper, was that it's on a rat IgG background, and if you administer it twice and with that particular antibody in small animals, it all goes to the liver. So it's there's a huge immune activation problem if you repeatedly administer some of these murine antibodies in mice, because many of them are on a rat IgG background. And there's very little literature of that. So you may think that of the immune antibodies in a mouse, and you may not be doing anything after the first administration. So I think there are a lot of things like that that are really big, can be big surprises, and that imaging tells us a lot about what's happening. So yeah, there are definitely opportunities to image, say, microglial activation or myeloid cell activation or T cell activation or specific T cell populations. All of that is feasible right now. The other complication in human trials is being able to look at a novel treatment with a novel imaging agent at the same time can be difficult to get approved for a human trial, and is the other barrier that I think we still have.
Thank you, Katie. Dr. Buha?
Yeah, so, just to second what Kathy just said, and also share one of our data. So we have what we call an artificial T cell synapse, where we essentially have a tetramer with a peptide with the linker. Now you can image or put a modifying domain such as 4-1BB ligand or PD-1 or whatnot. So it can be either an activator or an inhibitor. The story is what Kathy just said, that there is something special in mouse that whenever we are using even this tetramer, which is labeled, it just gets sucked in by the liver sinusoidal endothelial cells. So majority of these imaging tool immediately disappears in mouse, and we are trying to figure out what is the special receptor in the sinusoidal endothelial cells of the liver, which is a sink for these type of imaging tools. So that's one point. The other point is that many of us who will do the trial using either radiation or focused ultrasound might be looking for what we try to call as abscopal effects, in other words, the unradiated or untreated sites. And what was amazing in our clinical trial of 29 patients is that the PET scan, even the FDG PET response of the unradiated sites within 2 months to 4 months of your treatment had a correlation with overall survival. So in other words, as great as we talk about all this inflammation after immunotherapy, usually the patients who end up coming to us have been through immunotherapy and is slipping through the immunotherapy, meaning there was maybe initial some response, but as you give these cycles of immunotherapy, you essentially made it cool. So all these PET response doesn't exist in that group of patients. And now when you do your focal therapy with immunotherapy, look at the ones which you did not treat with focal therapy, and there is a PET response. That response has to be related with the systemic immune response which you have induced. And at least in our trial of radiation and FLAG3 ligand, it was highly significant, that response in the unradiated sites, highly significant to overall survival.
Yeah, thank you. Dr. Frank?
Yes, I just want to comment on the liver uptake just briefly. Chen Ho at Carnegie Mellon years ago used to give intralipids before they did any of their experiments to block all the scavenger receptors in the Kupffer cells in the liver and spleen. And if we wanted to increase the circulation time of some of these antibodies or tagged antibodies, it may be worthwhile considering giving intralipid and then essentially following up with the radio labeled probe, that whatever you want to use, to see whether or not you can actually avoid liver uptake and try to get it to go to other places. So that's one of the ways that we have approached this as well, as trying to just block some of these scavenger receptors that you see on macrophages and endothelial and variety of other cells, and just to keep things in the circulation longer. It was just a comment. It wasn't meant to talk about the imaging part or anything else, but that's sort of one of the sort of things that people may want to consider if you can do that.
Yeah, to continue on this line, Tim Bullock put a question on the chat to ask if the clearance that you are seeing is simply a function of the immune complex formation due to mouse anti-rat antibodies. So you think that's a reason?
It's a one way you can potentially, I mean, there's still going to be a mouse antibody interaction, but if everything's winding up in the liver because it's basically immune complex, then you could block some of that as well.
Okay. Do you have any other comment or question on this line? Or?
Well, the other question is, I think there was a question by Tim about myeloid cell. I mean, people have used femoxytol or some sort of superparamagnetic ion oxide nanoparticle to look at macrophage uptake and look for tumor displacement in lymph nodes and things like that in the prostate. And there's still a possibility of being able to use that with MR to actually answer some questions if you're clearing. And that you could do once and come back 30 days later and do again, because just the T2 star abnormalities last too long.
Yeah. So moving a little bit from the technicality, let's say, of PET imaging to imaging in more general, I'd like to ask a question to Dr. Lavallee about the bioinformatics analysis that you presented of the PRINCE study. So just a general question in terms of logistics to see how these kind of clinical trials are set up, where the analysis performed at each site, or for example, for all these bioinformatics data, or did you do it at the Parker Institute? How do you set up this type of trials?
Yeah, so the Parker Institute is the sponsor, and we have a biorepository. So we run the clinical trial, collect all the clinical data, and we have monitors and a database, all of that. The samples are collected at the sites, but shipped overnight to a central repository for harmonized sampling processing procedures for the majority of the samples. The serum is processed locally. And then we coordinate all of the assays. So with a variety of either CROs or with academic sites. So like our X50 panels, those T-cell panels for flow cytometry are done at UPenn with John Weary's team. But then like the CyTOF panel is done with a CRO. So it was Matt Spitzer. I actually said it wrong there. He's gonna get me. Their panel, and have worked with Cellcarta, I think is the company now. They've had a couple of change of controls. We are interested in the Cytek technology, and that may be more robust. And so are looking at a pilot project on adapting the panels to that. So I think Q2 has an amazing immunology group there. So as you're having discussions with them, they've really impressed us as well. And then the key is, one, the complexity of just moving all the samples and getting the assays done. You don't have to do all of them, but I think you could have a core set of them, and then getting the data in with all the controls and getting them into a database. So we've spent a lot of time on really working on the gating, the order of which we call the different T-cell subsets. Then our bioinformatics team at Pisces have built what we call Candle. It's a database that is a repository that enables analysis across clinical and biomarker data sets, so that we can look, and they've ingested data from pharma companies and academics on different samples and data sets, as well as literature, to be able to increase the analysis. And so it's very nice in that when we look across the blood parameters, the tumor parameters, and the clinical parameters, they can do that type of analysis to look for the integrated type approaches in both directed approaches and unbiased approaches.
Yeah, that was very fascinating. Yeah. And again, going back to the question of tumor samples and blood samples, so you learned a lot from the blood samples. In this specific case of pancreatic cancer, would you be able to learn a lot with only the blood samples? Oh.
And I think that's what we showed. So what we found with the tumor samples, we have the baseline even was very informative. The issue for the on treatment, it's the devil in the details, as we always say. So we had a remarkable biopsy acquisition rate, I think, for a metastatic pancreatic cancer patient population, an 80% baseline and 40% on treatment. When you then go to what percentage of those are matched lesion biopsies, what we found was that if the lesions didn't come from the same anatomical site, we got big differences. And so to compare pharmacodynamics, they had to be from the same site because the heterogeneity was large if one was from the liver and one was from the pancreas, for instance. And then we did find big differences when we did the comparisons for the population if they were from the different sites. So we limited the on treatment looks and changes to match liver biopsies. And then the sample numbers were a handful, 4, 5, 3, depending upon the test and the analysis. So instead of having 35 patients to look at, we only had a handful of patients. And so in our follow-up study, where we're looking at additional novel concepts for treatment, we actually are working with the sites to really make sure that we're getting matched biopsies, of course, when medically feasible, from the same anatomical site.
And it is bioinformatics tool or database, is it public domain or is it restricted to collaboration with the Parker Institute?
Yeah, so the complexity, so we are a nonprofit and look for collaboration. So there has to be a collaborative model. Since our clinical trials are in collaboration with CRI and pharma partners, they have proprietary information. So like the Prince study, we're actively working on. I mean, we literally just finished the full integrated analysis for a story. So the time is really important because we took a dedicated couple of months to really get through all of that data. We finished it like 2 weeks ago, and our target submission time for writing it all up and getting it to the journal is in December. So we're trying to get it out as rapidly as possible so people can see it. And then we can publish the results, because then it would be publicly available. But Candle doesn't have full access to just anyone, although tools, our informatics team has made a variety of tools that are available to other people. And depending upon what the questions are, dashboards can be set up for other folks to look at it.
Okay, thank you. Dr. Guha? You're muted.
Sorry. For the pancreatic cancer study, because we have 2 trials going with a special type of radiation which uses carbon ion instead of X-rays. And the goal is that, carbon ion being a mass and a charge has more complex DNA damage than simple X-rays. And one of the things we always have a problem using radiation is that the blood is an organ at risk and we cause lymphopenia, right? I mean, it goes through the spleen, or even pancreatic cancer is encasing superior mesenteric artery, so a lot of blood, and so you cause lymphopenia. And in that setting, and just focusing on the blood, we see a very strange event that while majority of the TCR diversity profile, alpha beta goes down, but IgM and gamma delta diversity goes up. And so I'm asking that in pancreatic cancer, especially with mouse models, there have been some controversy about tumor infiltrating gamma delta T cells versus circulating gamma delta T cells, which may have different impact, where tumor infiltrating could be suppressive, circulating may be more activating. So in your experience using, yeah, go ahead. You were already smiling, so let me hear what you have to say.
Yeah, and like I said, it's such a mountain of data. So we do have in our CyTOF panel gamma delta T cells, and there are some findings with it. I don't remember off the top of my head. We don't have the ability to look at them. Our imaging panels that we used for this study were vector-based. And one of the disappointments we had was the ability to look across panels, and you're really limited by the number of markers, and gamma delta didn't make it there. But I think it's, again, I mean, going back to our discussions about we have an immune system, while the T cell is a major focus, the other cell types do matter and contribute, and really paying attention to the system is something of importance. But that's the best I can answer your question, which isn't perfect for you.
Well, no, just to continue, and for the group in general, there are certain types of ultrasound injury, mostly in the mechanical realm, where lipids might be an antigen. And we are seeing that lipid antigens may be important for immunosurveillance of senescent cells, and therefore CD1D best presentation with NKT cells, and now gamma delta. I'm just encouraging all of us to look beyond just the CD8 CTLs, which we all do, rightfully so. But anyway, that's my comment. Thanks.
Thank you. Dr. O'Donnell?
Yes, thank you. Just to follow up a little bit more on a practical basis, when I try to think about the role of Focus Ultrasound Foundation could have, CRI has tried for many years, and we've had a clinical strategy doing multi-center trials. And our original strategy was really trying to harmonize various immune assays across sites. And I want to say that after 10 years of doing that, it was, I think, disappointing. And I want to just put a plug in as you're thinking of trying to coordinate multi-center trials, looking at what Focus Ultrasound could do immunologically. I think the collaboration that we have set up with PICE has been a major boon, having everything centralized. It's really, really important. As much as you try to harmonize assays, I don't think you can accurately do that and bring it in. So the fact of setting up a centralized lab where the samples get shipped and put together, and then coordinating those assays, whether they be in-house or external, is extremely important, I think, in that. And I think building up the database and having a bioinformatics team that is able to analyze the amazing amount of data that can come out of trials when you're doing kind of these multi-omic panels require a team of bioinformatics that can do this. And I think centralizing this is the way that you can really have the field take a step forward rapidly. Instead of having individual trials all over the place, not coordinated, this whole kind of centrally directed and having a very active role with the team that's in the center, as well as the individual site and investigators, having input at the design, having hypothesis-driven trials, knowing what the question is you're trying to ask when you're designing the trials with the experts that are not only tumor type, but tissue type experts, because we know it's all very different. If you're in the pancreas and the prostate and the liver and the brain, that is extremely important. And as a way, I think, to more effectively accelerate the discovery. So that would just be kind of having seen this go on for almost 20 years at CRI, the role that we are now in seeing that the centralization, I cannot tell you how much that makes a difference. And so I just plug that out there as thinking as the roadmap for the Focus Ultrasound Foundation of something to consider.
Yeah, thanks a lot. And this is exactly the path we are trying to follow with creating this core lab and in this collaboration with Quest and Q-Square, at least for the analysis, for samples analysis. Now, for the bioinformatics part of it, something we need to develop or to think about. And before to wrap up this discussion, I mean, are there any other suggestions or comments or wish list of things that the foundation could do to help us move forward? So no wish list. I mean, it's time to ask. Okay, so maybe we did a good job of discussing these different points. So I will give the mic to Jessica.